So with that, it is going to be my pleasure to introduce our Grand Prize Award team, the COVID-19 Cancer Consortium, CCC-19, and the lead, Dr. Jeremy Warner. He's a professor of medicine and a professor of biostatistics at Brown University. He's also the associate director of data science at the LaGuardia Cancer Center in Brown University, and he's an attending physician at Lifespan Cancer Institute. He is the lead, one of the leads on the COVID-19 Cancer Consortium project. This project made impactful shifts in the care of COVID-19 cancer patients using really innovative systems for sharing data that was much needed in the field of cancer. And Jeremy, thank you so much for being with us today. I'm really looking forward to your seminar, and congratulations on the win.
Thank you so much. Can you hear me okay? And is my video okay? Okay, great. So what I will do now, hopefully this will go smoothly. I have two monitors, so I just have to make sure. Are you seeing the full screen or are you seeing presentation mode?
We're seeing full screen. Looks good.
Perfect. Okay, well, thanks so much for inviting us to give a talk today. My goal is to keep this to 35 minutes and then have time for questions. And so I will try to do so. Just a few disclosures before I get started. So I have grant funding from NIH actually supporting this work now, as well as some other sources, some consulting, ownership, and editorial, as you see here. So what I'm going to try to do is cover mostly our background information and a little less about our results, although I do like to share some of the results that we got through our work. And then I'll talk about what I guess we call our recipe for data sharing and reuse, which is certainly one of many, but seems to have worked in these almost unique circumstances. So who are we? What is CCC-19? So we're a large consortium, over 100 North American institutions, patient advocates, and independent researchers who all came together around a unifying goal in the pandemic, which was to understand what was COVID-19 going to mean for people with cancer. And we define that very broadly as someone who had a current diagnosis or had ever experienced a diagnosis of cancer. I have to point out that our team that submitted this application was only a small part numerically of the consortium. I'm listing the folks here. There are about 10 of us, but we couldn't possibly include everyone, but we're very grateful to all members of the consortium. So this is who we are and where we are. So we tracked as time went on geographically where our participants are, and you can quickly see that most of our sites are within the United States, but we do have several sites in Canada and Mexico, which is why we call ourselves North American. This is actually partial and not in a little bit outdated list of all the investigators that have been involved with CCC-19 in one way, shape, or form, well over 600. Many of which have been co-authors of papers, as well as have provided a lot of the work to build the registry. We are the largest registry of its kind, and I say of its kind because there are definitely larger efforts that are primarily based on electronic record sources, such as billing, claims, and electronic medical records. What makes us a little bit different and unique here is that ours is actually built on manual curation and really teamwork to pull some of the more difficult variables out of patient notes. And because of that, we have a picture of COVID that's a little different, and I'll talk about a little bit as we go on. Compared to around the world, where, as you can see from the table here, there are other efforts, mostly in Europe, and those are also large. But in just terms of sheer numbers that we ended up recording in our registry, we are the largest there. So now I'm going to go from largest to smallest. So I moved to Rhode Island 2 years ago. We're the smallest state in the country. Some of you couldn't spot it on a map. But what I like to point out is that we have a very important piece of American history that I didn't recognize until I went on a nice bike ride just a couple miles from my house and came across this. This is called Slater Mill, and this is a one of the very first factories built in our country, which actually started the American Industrial Revolution. And the person who built it, his name is Samuel Slater, and he earns this moniker Trader Slater, which is interesting because, in fact, this was pre-revolution, so he was or just post-revolution, I should say, and so he was felt to have betrayed the motherland of the United Kingdom in England. But in fact, what he didn't, what he did was he borrowed ideas. He didn't actually steal things. And I think this is actually a lot of what we're about as well. So when CCC19 came together, our key theme was borrow best practices, don't reinvent the wheel. And so as far as Samuel Slater goes, just very briefly, what he did is he apprenticed as a textile technician in England. At that time, it was illegal to take plans or blueprints or anything like that out of the country. That would be considered industrial espionage and theft. But he memorized the plans. He memorized the designs. And then when he came to America, he was basically inspired by these thoughts and memories, and ended up, basically, kickstarting the American Industrial Revolution. I think, when you think about what is DataWorks all about, what is open science all about, it is about imitation to some degree. Like, there's a lot out there that we need to be inspired by. And this is what I think we should all do. We also follow the CC BY approaches. And so just briefly for those who don't know what this is a Creative Commons license. And, the idea here is the work that we do, the work that we do, we want others to, we want attribution, basically. So we want others to borrow, adapt, change what we've done. But certainly if they're using data that we've collected or, ideas that we've created, the idea here is that they should attribution. And perhaps Samuel Slater was a little short there because I'm not sure he appropriately attributed, but this is that license. We are not licensed, but I just point that out as sort of like the idea here. These are our inspirations. I obviously don't have time to go through each and every one of these, but it turned out that building a consortium from scratch was quite complicated, had quite a lot of different variables to consider here, ranging from how to structure our governance to how to actually build our data model, to how to get people to know about what we were doing, and importantly, those people being patients as well as healthcare providers, and so forth. So these are just a few of our influences. We also had sponsorship, and going back to Samuel Slater for a minute, this is also near and dear to my heart because my daughter goes to Moses Brown School here in Providence, and it turns out that Moses Brown, who's an early Quaker abolitionist, was the sponsor of Samuel Slater, actually helped him get the mill going, gave him some money to build the mill, and got that going. Well, our sponsor actually didn't give us any money. What she gave us was attention and sponsorship and basically some of the secret sauce that we needed in the early days. And that's Julie Clem, who's the director of the NCI Informatics Technology for Cancer Research program. So I'm very grateful to her. So why were we worried about patients with cancer? I just want to kind of give you some background there before I get into the consortium. So, really our major worry related to the idea of immunocompromise and the fact that cancer itself is an immunocompromising condition, but even more so, the treatments for cancer can be quite immunocompromising. Those could be steroids, as these examples show. They could be a combination of steroids and other medications which disable parts of the immune system, such as rituximab, other drugs like BTK inhibitors. Not insignificant number of patients with cancer have undergone transplant of one sort or another. So they might have had a solid organ transplant and be on a medicine like tacrolimus. And then really pertinent into our field, a lot of our patients are getting immunotherapy, which revs up the immune system, but also to destroy cancer, but also can cause other issues with the immune system. And it can also lead to needing secondary medicines to control the immune system if it gets out of hand. The other issue that even back in March of 2020, when we got started, the very early reports had shown that age was a huge factor, and we knew that people with cancer tend to be older, and this actually shows that our population, so the yellow is our registry, the gray bars are SEER, which is our National Cancer Registry by the NCI, and you can see that our bars are much closer to the SEER bars than the general COVID population, which is the orange and the blue. So indeed, patients with cancer are older, and that's the group that's getting COVID. We were hopeful in the early days that some of the cancer treatments that we use could actually help treat this virus. And we had a number of different hypotheses around that. And we haven't necessarily proven or disproven these yet. Believe it or not, there's still work to be done. But one thing I wanted to point out again is this immunotherapy. And I just pulled this list of drug sales around the world. And you can see that the top line there, which is an immunotherapy, pembrolizumab, is far and away the top selling drug in the world, almost double the next one, which I think you all recognize. And so I think that was, really eye-opening just to realize how widely these drugs are being used for so many different cancer indications all over the world. So again, sort of in the early days, we put together this sort of structure here about the factors that we thought could lead to severe outcomes in patients with cancer. And those factors had to do with the biology of how the virus enters, as you saw upper left, as well as on the upper right, the factors related to cancer itself, including those that are related to the immune system. And then there was also a story on the bottom there about arterial and venous thrombotic events, which are also, if you know about cancer, those are also quite common in cancer, as well as COVID. So those were the kind of the three things we were worried about. So now I'm going to pivot again and go back to talking about the consortium and what our early days looked like as we got going. So we give credit to Dr. Akash Desai, who I cannot believe that he was a resident when this started. Then he became a fellow, and now he's a faculty member in Alabama. So we've kind of seen him go through his whole training and development. So at that time, he had tweeted out this what you see here, this tweet. And I think what's interesting here is that this went viral. It tags the right people. He himself didn't necessarily have a lot of followers, but the people he tagged had thousands, tens of thousands. And this tweet just kind of ballooned and went viral. And this was on March 13th, 2020. And what happened within 3 days of that tweet is that offline, an email thread began. And I was part of that thread, and you can see, members of 5 different institutions. And I think one important thing to note is that we were all clinicians, and this was kind of coming from our, somewhat from our perspective, from our clinical perspective. We discussed, the feasibility of starting a data collection effort. Actually, within those first 3 days, we applied and received IRB exemption to start our registry. Excuse me. We built our survey, version 1. We created it, we tested it, and we launched it. So we went live within 3 days. And then we just really used social media and just, good old file sharing activities like Google Sheets to start to build our community, and email for that matter. So, moving beyond that, in the first 2 weeks, very early days, obviously, we created a logo, a mission statement. We obtained a website. I'll say a word about that in a minute. We started building our governance structures. We created a steering committee. We created a charter, and we really just had open doors. We said any interested cancer center should come and join and work with us. We did begin collecting cases, as I mentioned, and then we started really socializing the idea. So I really like this story. So when we went to get a website, so websites, the best website is a short, easy to remember. So we went to ccc19.org. It was taken. It was taken by the Climate Change and Consciousness meeting that had happened in 2019. And so, at first we're like, oh, that's too bad. But then we noticed this little thing in the corner. It said, if you have any questions, email us. contact us through this form. So we did. And believe it or not, this organization was like, what you're doing sounds important. And we're giving you the website. Now, remember I said there was clinicians that started this thing. We had really no idea how to manage a website transfer, but our community had built to the point where we could borrow expertise and figure out these things that we didn't ourselves know how to do. Same thing for a logo. Someone knew someone who knew someone who knew a logo designer, and they put that together for us. So kind of a lot of stuff came together in that first 2 weeks. I do like to just say a word about this organization because it turns out they're also really interesting. So it's called the Findhorn Foundation. They've been around since 1972, and they focus on sustainable living through eco-villages, which is also kind of, you know, maybe within this general idea of open science and transparency, if you will. Okay, so moving on to the first month of our existence, probably one of the most important things we did was recruited project manager who's Sanjay Mishra, who's fortunately still with us and still very active in our consortium. And we instituted a deadline. And why did we do this? So I think number 2 here, if we hadn't done that, things might have gone differently. Well, this was where we were at the end of the first 2 weeks. On the left, you can see the growth in site membership. We had already grown to over 40 sites 2 weeks in, but on the right, you see the growth in the number of cases that we were actually accruing, and it was lagging behind the number of sites. So at this point, I think we could have thrown in the towel. We could have just said, well, this is an interesting idea, but nobody's actually reporting cases. This was, you know, this was cool, but maybe they're not, maybe patients aren't getting COVID or, you know, whatever it might be. But we decided to keep going, right? And so instead, what we did is we sort of did a media blitz. We ended up writing a bunch of editorials. We did a bunch of interviews, mostly inside of our community, but our community is big, as I'm sure you know. Cancer is the second leading cause of death. It's a very big group of people that are interested in it. So we spoke with all these different media outlets. We did podcasts, we did interviews, and something really started to happen, right? So this is what happened. So this was our first 30 days of existence. And by the end of that 30 days, in that horizontal green bar, there's our data lock date. We had collected over 1,000 cases, and they really didn't start coming in until that last 2 weeks. So I think this is one interesting takeaway here, is that sometimes it's almost like a carrot and the stick thing, right? Like, so maybe a data lock is a bit of a stick, but it seems to actually work. And one thing I like to point out here is that these gaps that you see, so every red dot here is a case that got submitted. The gaps you see are mostly nighttime in North America. So we think people were sleeping and then they'd wake up and report some more cases. And then you see the last 2 days here, even during the night, all through the night, we're getting cases coming in. So that was pretty amazing to see. And we were able to put together, you know, I think a meaningful manuscript that may have, I think at the end of the day, saved lives. Here we did, so we did it, so we say it worked once, let's do it again. We did it 3 more times in the first year. We had 4 data locks total, and you can see each time sort of a jump in cases. And then we said, look, we can't keep doing that. You know, we not only are we pushing people to their limit, but the quality of the data coming in may not be the best in those final hours after they've been up for 48 hours and they're still working on reporting cases. So we stopped those. We kept getting cases. This is not quite to the current, but you can kind of just see that over you know, almost, you know, 3-year period here, we just kept getting cases coming in as new sites would come on board and report and so forth. I'm going to actually come back to that. Okay, so now I just want to say a few words on you know, what we found, especially in the beginning. And so the first thing we found, really, the take home, is that there are high rates of complications, which is what we were afraid of. But you know, we had to look to find out, including mortality and other important severe outcomes, such as needing a ventilator or an ICU, or basically being hospitalized. And you see here a couple of snapshots over time, the early, and then, you know, by the end of 2022, when we had almost 14,000 cases. And you can see Some of these rates dropped a little bit, but the rate of hospitalization still remained quite high, above 50% as the pandemic wore on. And as we start to look at subgroups, we saw that certain subgroups had really quite worse outcomes than others. So overall, you see the red row, we saw 14% mortality at 30 days, and that was worse than these global statistics, no matter when you looked at them. But if you looked at the subset of our patients who were very healthy, had no comorbidities, they had a mortality more comparable to what you might say is the average population. But on the other end of the spectrum, older folks, especially those that did not have the strongest performance status and were on, say, a ventilator, had extremely high mortality rate. We also saw that there was a range across cancer types. So if you look this is now pretty well described, but back then, we saw, okay, there's a spectrum here with lung cancer and cancers like that being associated with quite bad mortality rates, as well as hematologic neoplasms, which kind of makes sense when you think about that immunocompromised issue. And then on the other end being things like thyroid cancer, breast cancer with lower mortalities. One question that came up really early, and still is a question for us, is are these folks who pass away, are they dying from COVID, and if so, is it related to lung disease or something else, or is it their cancer, which is certainly possible in many cases. And what we showed early on is that for the majority, it was related to the COVID and to their, in particular, the pneumonia and the respiratory failure. We plan to look at this again with larger numbers, but that's going to hold, I think, when you look at short-term outcomes. When we look at a couple of subpopulations, we see subgroups that might be like at especially high risk. So for example, if you look at the patients with a blood cancer, a hematologic malignancy, here age seems to be, it's always worse the older the person is, but even in the young ages, we see high mortalities, and 5% in the age group of 18 to 39 is quite concerning. That might relate to the fact that they've undergone transplant, for example. And more work needs to be done on this. Again, this question of immunosuppression, and we came up with a definition based on our data for immunosuppressed. And again, we see younger patient, a bigger discrepancy in the younger groups. So if you look at the first row of both tables, on the left are people who are not immunosuppressed at baseline. They have this 2% mortality, which is kind of the global average. And on the right, that same age group has a 7.5% mortality. So a huge difference. The older the patients, those differences start to attenuate. And then sort of another layer on top of that is, do they have active cancer? And here we actually finally find a group of patients that did not have any mortality in our registry. So if they're not immunosuppressed and they don't have active cancer in those young patients, they seem to do quite well. Whereas on the other hand, active cancer actually increases these mortality numbers. So one thing I don't have time to do in 35 minutes is talk about all of our work. And what happened pretty quickly is that we realized how much we had to look at. And what happened is we created all these sub-projects. We began published 3 papers in 21, more in 2022, more in 23, and we're still publishing. So we just published last month a paper looking at whether the actual site of cancer, where the cancer is in metastatic cancer, has an influence on outcomes, and it does. We've published many of these as abstracts, which eventually we'd like to see go to full papers. And our work is not done, but what I'm going to do now is actually pivot to our recipe. So hopefully that's given you a taste of the things we've been looking at so far. So what is our recipe? So our recipe really builds, or sort of the foundation is the FAIR model. And hopefully everybody here knows what this is, but just a quick review. FAIR stands for findable. So you should be able to find, for example, a data model. So we make our data model public through GitHub. It should be, I think if you, and we have that website, right? So you can find what we're doing. It's accessible. All right, so is the A. So we make this freely available, this this data model and all of our publications. Interoperable is the idea that whatever data model you're using should be able to coordinate with others. And we've shown that we can do this. We use REDCap, which is widely used, and we've tried to follow data standards. And then reusable is the idea that data are adhering to an existing standard, so you can reuse it for other projects. So to get that into that a little bit more, the idea here, so we're working with many different institutions, right? So we had a couple options. We could either ask each of them to maintain a local database and then give us the results, or we could maintain that's called the federated model, or we could maintain a central repository. In the end, we actually did both. So we have a hybrid. Most of our data was collected centrally at Vanderbilt University, but we had about 10 or 11 institutions that did choose to create their own registry, their own sort of photocopy, if you will, which actually led to some problem. I'm happy to talk about that during questions if you have any. But they wanted to do that, and so then we would bring in that data during analysis. So as far as data sharing, again, I mentioned our data model is open source. We try to make all of our publications open access. I have a few dollar signs here, maybe add a few more. I mean, the issue here is that open access fees are very high, and we depend on public funding. So, we're fortunate to have NIH funding now, but it doesn't really cover these fees. So we have to think of another way to do that. Everything we publish will be listed in PubMed Central after the usual embargo, but we wanted to make our work available immediately, and that's where those fees started coming in. I'm going to say it again: don't reinvent the wheel. Okay, data sourcing and acquisition. So one of the takeaways here is that we were, I say relatively, but COVID-19 and cancer, having them together is relatively rare. As time has gone on, more and more people have obviously gotten COVID. It's not that rare anymore, but we needed multiple institutions. We never could have done this with 1 or 5 or 10. We needed everybody to participate. We worked within the de-identified data world, and that made things so much easier as far as the regulatory burden. And it even allowed for us to collect free text. I'll say a lot of our inspiration here does come from AACR Project Genie, which is also a registry that collects data on patients with cancer who've undergone genomic sequencing, which is a very different population. But if you think about it, it's sort of the same idea that you start with a population that's somewhat common and you add something that makes it uncommon, and then it often needs a registry or similar. As far as data management, we never locked our data model, so I think that's important to point out that we had to be flexible. When we started, there were no vaccines, and then there was a couple of vaccines, and then there were boosters, and then on and on and on, and we constantly were having to add and modify our data model, which if we'd locked would have made everything harder. We used REDCap, as I said already, which was widely used, familiar to a lot of people. We instituted something called a quality score, which had to do with both the completeness, so how much data that was registered was missing, as well as some other metrics. And we were this is sort of, again, like sort of this carrot stick model. We ended up coming up with this gradation scale for the participating institutions. And for this, we were inspired by the Center for International Blood and Marrow Transplant Research, or CIBMTR, which does a similar thing. So this I skipped over before, but I'll show you now. This is kind of what has happened over time, is that the institutions participating have ended up in these tiers, and we use this to determine authorship, for example, eligibility when we are writing a new manuscript. So I kind of think about what we do sometimes as foraging. So this is the best picture I could find for foraging. So how can we forage from our experiences? So these are kind of the principles that we have, the three principles. One is team science and data governance. Collaborations were sparked through social media, but that was a beginning, but definitely not an end. We needed a unified vision, and that was to some degree both top down by a steering committee as well as bottom up by collecting input constantly from our consortium members. Dissemination is so important, so constantly through social media, conferences, publications, we're sharing what we've done. Our principle 2, again, is this flexible data infrastructure. There are upsides and downsides to having a flexible data model as opposed to a locked concrete model. I will just again say that REDCap was a really nice solution for us, even though technically REDCap itself is not open source. It is so widely used. It's accessible, it's adaptable. And our third principle is transparency. So our on all sides, curation, right? We outline our curation process, our analysis. We try to make our R code available, for the analyses that we run whenever that's feasible. Right now, we are working towards making data more openly available. It's a little hard to do row level data due to our charter that basically requires that we obfuscate to some degree so that we avoid any chance of re-identifiability, but we're going to work through that, and we're going to make our data as available as possible, and as I said already, open access publications. So I just had a few closing thoughts, and these thoughts revolve around the principles of informatics, which are people, process, and technology, which really come into play here. So as far as people, it's, for something like this to come together, I think it's critical for the majority to be aligned on mission and vision. One thing that we learned by, just by trial by fire a little bit is that not everybody's going to agree with every decision. So I emphasize the word majority as opposed to consensus. Sometimes we had to go with something that wasn't universally agreed upon, but enough people wanted to do it. We found that goodwill, which was really ample in the early days of the pandemic, is finite, and you cannot expect people to do free work forever. So that's really important when you think about these kind of efforts. And then what I call the 3 R's: roles, responsibilities, and respect, which is something we always have to keep in mind, even when something's completely voluntary and altruistic. People need to know what they're doing, why they're doing it, and we have a code of conduct which we really had to put in place so that we're all sure to respect each other because we're people. Okay, so closing thought number 2 is about process. I would say that none of us really wanted to think about governance, right? We were in a crisis. We just wanted to get going and collect data, and but actually governance needs to be the first priority, because if you don't put something together that makes sense for the short term, it's not going to work for the medium or long term either. Regulatory burden has to be understood to be non-trivial. I like to use these venues to basically publicly say that I think registry-based research in a crisis should be considered for public health exemption. We were not, right? So what we had to do was get IRB approval. We had to use de-identified data. Well, public health data is exempt from a lot of these things. So public health can collect identified data, dates, things like this, and not necessarily have to go through IRB. And there's ups and downs to that. But now when we look back, there are certain things we wish we could have collected in a different way, which we did not. I already talked about the third point to some degree. Centralization and federation both have a role. And I don't think I don't think either is better. I think you end up needing both. And finally, technology. So I think, a question I have is, would this have happened today in 2024? I'm pretty public about this. I'm no longer on Twitter. I left it publicly. I don't know if I would have been part of this if it happened today. I think our social media platforms are much more fractured now, and I don't know what the future will hold. Another thing we unfortunately learned again during the process is that it seems like organizations cannot agree on which cloud-based platform is okay and is not okay. And I give the example here of Box versus, say, Dropbox or something else. And we found that some some institutions were fine with Box, but not Dropbox, and some were the exact opposite, and there was no rhyme or reason to it. And it did hamper us actually significantly because we couldn't share things with all of our consortium members that we wanted to. And then the last point I'll make is that open source software like R or low cost software like Zoom are often more than enough for this all to happen. We did not need to spend hardly any money on fancy software. We basically were able to do what we needed to do with basic things. So, that's about it. I just want to acknowledge, as always, the patients and their families who suffered from this terrible virus, and some of whom continue to suffer. We thank all of our institutions and participants, again, the Findhorn Foundation, and a lot of us had a little bit of funding support, so there's a lot of numbers here, and I hope it's here. I hope I didn't leave it off, but we are fortunate to recently receive a UO1 funding to continue this work for the next 5 years, actually. And so we will be thinking about how that looks as we pivot into the new phase of COVID-19. And so with that, I will end my slideshow and take any questions.
Thank you so much. Well, folks can ask questions in the Q&A panel at the bottom of your screen on Zoom. As people are thinking of their questions, I'll ask you maybe 2 questions, Jeremy. And by the way, congratulations. This is just an amazing amount of work. Totally fascinating. So my question really is around long COVID, because that's certainly of interest right now in our communities. I can imagine, and I think there's some evidence that folks with cancer and aging folks in particular also are at risk of prolonged long COVID symptoms. And I'd love to know if you're looking at that or thinking of looking at that. And then my related question is, are you leveraging and integrating the work that you've done in CCC 19 with the other data resources? We certainly have a number of those, the Recover data platform, which is by Data Catalyst, but also there's the National COVID Cohort Collaborative, and in a related activity that Mary Ellen Geiger will talk about, the MIDRC work. So with that, what is your thought about the work of long COVID in this work you've done now?
Yeah, great question. And if I'm not mistaken, N3C was the winner last year, right?
Mm-hmm.
So yeah, so the first question about long COVID, so we're very interested in that. And as I sort of alluded to at the end there, we're pivoting, and much of our early work was looking at what's the short-term outcome for patients with cancer and COVID. I think that's pretty much what's been said needs to be said as far as that goes. But now we're thinking about longer-term issues, and I think as with short-term COVID, the issues are different for people with cancer, especially those on treatment. So there's there's various definitions out there for long COVID, but I think when it comes to cancer, the real question in my mind is, does it influence people's ability to continue their cancer treatment, right? Because that's going to have maybe the biggest effect on their lives, right? So if they develop, I don't know, let's say a chronic kidney issue, is that going to mean they can't get platinum drugs as part of their standard treatment? If they develop brain fog, and how are we going to distinguish that from quote unquote chemo brain, or other side effects of chemo? Is it going to make chemo more or less tolerable? If peripheral neuropathy and so on. So the kind of list goes on and on, right? So so we're looking at that, right? So what we do know from preliminary analysis of our registry is that up to half, or a little bit less, about 40% of our patients who were on treatment had their treatment affected by COVID, and usually that was a delay, but sometimes it was a complete discontinuation. And I think that has to go into the definition, right? So when you think about what the long-term consequences are, if you needed a cancer surgery, but your lung function went down and you can't get that surgery anymore, that's a huge long-term effect. So we have sort of our own definitions of what long COVID is. I would say, what we're seeing in our registry is probably similar to others, which is, up to a quarter or so of patients might meet these definitions. We We don't necessarily collect symptoms longitudinally, so that's hard, right? So if someone has, prolonged, loss of smell, taste, these kind of things, this might be a little harder for us, but we're looking at that. And related to this, we're really interested. This is one of our goals of our U01 is to look at recurrence patterns for people who were treated and should be cured of their cancer, but we know that cancer does come back. And we really want to understand if COVID modulates that risk either up or down. And again, maybe it's being overly optimistic, but there's a possibility that for certain cancers, COVID might actually act as an immunotherapy in a way, and perhaps slow down or stop recurrence. So we're looking at that. As far as your other question, I mean, that's also part of our U1 is one of our Achilles heels, if you will, is that we don't have controls in our registry, because it would have been hopelessly impossible to ask people to curate the charts like they did for these patients, also for people without cancer or people without COVID. So we had to make that decision early on. But that's where something like N3C could really come in to help with us. And so we're planning to actually do sort of a matched or sort of some kind of comparison of our cases and use external controls, if you will. So we haven't yet started to investigate that, but that's like on our short path to begin speaking with them.
Thank you. Well, I see there are a number of questions, so I'll turn it over to Emily. I think she's going to moderate.
Yeah. First, let's start with Brian's question. Can you speak to the data curation process and if there's a publication or resources that outline the process or the tools that went into the data curation for your project?
Yeah, so we published, so I like to, this publication has no authors, but 300 contributors. Okay, so I'll put the link in the chat. I thought, this was important. We published on the governance and the process, as well as our quality scoring metric. And so I will just pull that up and put that in the chat in 1 second. I think, so we had a very unusual arrangement here, which is that we, sorry, it's showing up as a PDF. I don't necessarily want to put that link in there. Let me just see if I can get it as a, okay. I will work on that in parallel. So we don't know who is reporting the case. So it's anonymous. It's part of our de-identified structure. We know it's coming from an institution, and the people there at that institution know who they are, right? So they actually have local IRB approval. Most or all of them have local IRB approval so that they can go back and look at what happens, right? What happened at 6 months, 1 year, et cetera, so that we can answer this long COVID question. But centrally, we don't know who the curators are. So we have to rely on institutional resources. And we know that it was a mix of, I would say, trainees, registrars, like tumor registrars, so people who are specially trained in curation, as well as research staff that was being repurposed while they were sort of out of while clinical trials were basically shut down. We know it's a mix of these kind of things, but this is actually why we had to create our quality score as another way to evaluate the quality of the content that we were receiving. And I think we've shown that actually works pretty well as a substitute. Again, it's, this public health exemption issue. If we'd been under that kind of exemption, maybe we wouldn't have had to build this complicated structure. But that is the way it had to go. So hopefully that answered the question.
Yeah, no, that's very helpful. And I see your colleague Sanjay provided the link.
That's great. That's great. Yeah, because
I'll add that within the chat as well. The second question we have is to hear about how you handled the issue of institutions not agreeing on which cloud-based platform to use and maintaining the different data types organized and accessible across institutions throughout the project's life cycle.
Yeah. No, I mean, I don't think we've solved this problem. And I'll give you an example is that for the first 3 years or so, almost everything we did centrally at Vanderbilt was on Box. Vanderbilt abandoned Box. They decided to terminate that software agreement, and they are now using OneDrive, and that we still have not figured out how to solve that. So their migration from Box to OneDrive made it even harder, even internally, to share data for reasons that I don't entirely understand. The structure of each software is slightly different, and it's harder or easier. And, I think there's other overriding security concerns, I suppose. But I would say, unfortunately, we never solved it. And so I think some of our 600 participants have not even seen some of the files that we've put into our common shared folders, such as our SOPs and our minutes and our presentations and so forth. And that's unfortunate, obviously. So we are, this is one of the things we want to, we're going to take a deeper dive into institutional resources in the near future and kind of go back and understand more from sites, how they got around various issues. But I know that's sort of a non-committal answer, but I guess I have to say it's it's an unsolved problem.
Yeah, it's definitely a challenge. We had another question from another panelist, actually, expand on linking data quality and publication participation. I also had a question there about the sort of data grading and tiering approach that you mentioned, and both how that worked and what you might have learned from that for future work.
This is a great question, and I think as I said before, I think transparency always has to be front and center. So if you're going to do something that's going to more or less restrict access for one population while maybe facilitating access for another, I think you have to be very clear about that decision and why you're making it. So I will say, very early on, the first week or two, as part of our governance, we developed a publication and data use committee. And I think that's essential because that committee has, set forth the principles for which authorship will be considered. I think, we've gone back and forth on this. We can't have every person be an author on every paper. And I will say we actually had a journal, a high-profile journal, reject a submission because we had too many authors. All right, so just let that kind of sink in. Now in physics, I understand routinely papers have 500 or 600 or 1,000 authors, but that's not how medicine works. And so we're kind of, trying to fit within the confines of what we need to, as well as, recognizing that, some people, they, in some institutions, I say, like had, they had more input, they had more, higher quality and so forth. So, so we were transparent about all these decisions. I do want to emphasize we always follow ICMJE criteria. So we offer authorship to certain folks, but that's only if they go on and meet the criteria. So the other thing I want to emphasize too is that we've used this mechanism as a way to promote the role of trainees. We think that's really important. That's obviously our next generation, future generation. And so we've gone out of our way to encourage institutions, for example, if they get 2 author slots, one of them, they get like a +1 or something like that, where they can add a trainee. And we also really encourage co-first and co-last authorship. So we've kind of used these tools as a way to democratize, I guess. But to the question about it's in the chat, I think, but I don't know if you said it out loud. Did people complain? Of course they complained, right? We get complaints all the time, and I think every decision like this is going to make some people happy and some people less happy. And having a governance, obviously having I don't know if you want to call it a grievance or whatever you want to call it, but having a procedure in place to be fair and to be transparent, I think is what's always the most important thing.
Yeah, I also see that your colleague added some context around cloud storage, and folks can read that in the chat. I had a question as we're thinking about the work that your project completed, just to understand where do you see the impact of this prize on your project, and give us some context for what awards and challenges like this can bring to the work that you're doing.
All right. Well, first of all, I don't think any of us expected that we'd win this prize. So, I think obviously we're proud of what we've accomplished. We think that there's areas where we could certainly improve, but I think getting the opportunity to share with people kind of our trials and tribulations and what we've learned. I'd love to you know, I said it at one point, right, during this talk. I think we saved lives. I'd love to prove that. I don't know how to prove that. I think, you know, we influence behavior. It's not, you know, it's not so much, you know, yes, we had some, you know, some nice manuscripts. They got a lot of citations. That's good for our careers, whatnot. I don't know. Don't care about that much. I mean, we really did care about, you know, could we help people? Could we get a message out there? And I think we did. And mostly we've heard about that through informal channels, right? Like maybe someone wore a mask or didn't go to a crowded place, or, you know, undertook some precautions, got vaccinated, right? We've shown clearly how vaccination helps patients with cancer. So I think all those things have kind of come together and helped people, but that's a little nebulous. So I'm going to think about, you know, like how can we measure our impact? This is like the hardest thing that someone ever said to us. And, you know, at some point along the way, they said, like, what is your impact, right? Like, how are you showing your impact? I do think winning this prize is a big way of showing our impact, because I think the fact that that what we've done is important to the larger community does say something as well. So.
Well, I know we're reaching our time here. I really appreciate it, and I think you know, amongst all of the teams who participated in the prize, there was certainly some very big achievements and innovations that allow data sharing and reuse at the scale that you achieved here. So that's something that stood out when you think about why did we win this prize. So something very much to be proud of. Susan, do you have any remarks that you'd like to close things out here? I really want to also thank you for opening the session.
Absolutely, and I'll be staying on to listen to the other awardees. And I want to thank you, Jeremy, and your entire team, and also to all of the 123 centers that participated in the work, and all of the patients who contributed data. It made a big impact, and clearly the work goes on. And I look forward to learning more about the CCC 19 in the future with the new award from Cancer.
Thank you so much. All right, I'm very sorry to say that I have to go pick my